Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, Women's Pelvic Floor Disorder, the Science and Strategies. If this is your first time joining us for Cancer Support Community Atlanta program, we welcome you and invite you to visit that website on the screen, cscatlanta.org, where you can see a complete list of the virtual and in-person programs that we offer. We do so in a variety of ways. We have some great yoga classes, a monthly nutrition seminar facilitated by an oncology dietitian, some great support groups too. And I do want to highlight an upcoming virtual program we'll have later in March focused on women's intimacy and sexuality. So I'm going to put that flyer and the registration link for that free virtual program into the chat box. So we do invite you to join us later next month for that. But again, please visit our website, cscatlanta.org, to see a complete list of everything that's offered. And I am excited to welcome Mira Merille back to this virtual platform. We're excited to have both Mira and Dr. Ford back for this discussion. Mira is a board-certified specialist in women's health physical therapy. She has over 8 years of experience specializing in the treatment of pelvic floor dysfunction. Mira is highly skilled in the treatment of urinary and fecal incontinence, pelvic pain, sexual dysfunction, pelvic organ prolapse, voiding dysfunction, and constipation. She prioritizes individualized, evidence-based care to each of her patients at Northside Hospital in Atlanta. And with that, Mira, I'm going to pass it off to you to begin today's presentation.
Thank you so much, Katie. I am happy to be here. I have the pleasure of introducing Dr. Alexcis Ford. Dr. Ford is a Harvard-trained double board-certified physician in obstetrics, gynecology, and urogynecology and reconstructive surgery. She has been with Advanced Gynecology since 2019 and currently serves as Chief Medical Officer. Dr. Ford has extensive experience with both surgical and non-surgical treatment of a wide array of pelvic floor disorders. She also specializes in the management of pelvic pain, including vaginal mesh removal, as well as treatment of fecal incontinence and rectovaginal vesicovaginal fistula repairs. Dr. Ford is passionate about providing holistic, women-centered care to her patients.
Thank you very much for that wonderful introduction, Mira. So yes, it's great to be back here. I think it's been a few years since we did this the last time. So happy to hear that there are some new faces and new names here to learn about some new things. So I'm going to be talking about the sort of surgical kind of medical side of managing pelvic floor disorders. So we can go to the next slide, Katie. I'm going to explain what the role of a urogynecologist is in care. What is a pelvic floor disorder? What are the two different types of pelvic floor disorders and their treatment? There are lots of different types, but we're just going to focus on two of these disorders. And then we'll discuss the impact of specifically gynecologic malignancies, but some of these can be kind of extrapolated to other sorts of malignancies that have similar treatments. And then we'll review the role of the cancer patient and the oncology clinician provider in identifying and treating pelvic floor disorders, which is, as you'll see, it's not done enough. So we can go to the next slide. What is a urogynecologist? I get this question every single day, and it's honestly, it's bad marketing on our part. We're not European gynecologists, as I've once been asked. We are folks who have either a urology or a gynecology background, and we do additional training specifically in pelvic floor disorders and pelvic floor surgeries. You can have an either 2 or 3 year fellowship in what was once called female pelvic medicine and reconstructive surgery. We've now changed the name, so it's a bit more clear to urogynecology. We don't manage cancer. We don't treat cancer. And so that's important to know. A gynecologic oncologist or a urologist or urologic oncologist will manage those things, but we certainly manage the things that coexist in cancer patients. So next slide. Pelvic floor disorders, what are they? They're a group of disorders that affect the pelvic floor. And generally, this is due to weakened pelvic muscles or tears in connective tissue. I sort of focused on that definition for today's talk, but there are other conditions that can be caused by spastic pelvic muscles or tightened pelvic muscles, which is another issue. Listed are some of the things that we deal with, but generally speaking, urinary disorders, fecal disorders like incontinence or inability to urinate or defecate, prolapse, which we'll talk about more today, fistulas or abnormal connections between the pelvic floor organs like the bladder, the bowel, and the vagina. Different pain syndromes like interstitial cystitis, as well as issues with mesh, which we won't be talking about too much today. Next slide. So how common is this? Extraordinarily common. A quarter of women will have at least one pelvic floor disorder. That skyrockets if you've had a vaginal delivery, where close to 8 out of 10 women will have some form of pelvic floor disorder. Overactive bladder is by far the most common. We'll talk about that a lot today. Stress incontinence, as well as common fecal incontinence or leakage of stool is a little less common, and then prolapse is common as well. So, of course, I think intuitively these things increase in prevalence with age, and nearly 50% of women have at least one pelvic floor disorder by age 80, and close to now it's, at the time we gave this talk, it was 11% of patients will have a surgery for a pelvic floor disorder by the time they turn 80. It's now 16%. So it's increasing, definitely. We can go to the next slide. So what are the various risk factors? I touched on this, but advancing age, higher weight, so higher BMI, estrogen status, which is extremely relevant for today's conversation. So less estrogen usually equals more pelvic floor issues. Activity levels, if you're very active, usually more pelvic floor issues. If you've had a lot of babies, if you've had a lot of vaginal deliveries, if you've had operative vaginal deliveries, so forceps or a vacuum, or if there have been really bad tears or things like that, or difficulty healing from tears during vaginal deliveries. Surgeries that can contribute, a hysterectomy, really for any reason, can contribute to pelvic floor disorders, and then certainly oncologic reasons, specifically radiation, types of surgeries done for cancers of the pelvic organs. For example, the way a hysterectomy is done for cancer is different than for benign reasons, and that in and of itself can cause pelvic floor issues. History of pelvic floor issues is a risk factor for future ones, so urogynecologic surgeries in the past. Different orthopedic surgeries, neurologic problems can cause pelvic floor issues, and then other conditions that affect nerves, like diabetes, different vascular diseases, smoking, and then having intra-abdominal pressure issues, where there's constantly a lot of pressure in the abdomen, can just push down pressure on the pelvic floor. So issues with coughing, sneezing a lot, straining with constipation. Having radiation can make tissues just not flexible. And so there can be a lot of pressure that is placed intra-abdominally because of that. Different, I didn't write these down, these are a bit more unusual, but extensive burns where there's really tightness of the skin, that can cause issues as well. So we can go to the next slide. So we talked about, we're going to focus on a couple of pelvic floor disorders. So next slide. We're going to talk about the most common one. So overactive bladder, or OAB, you'll see it abbreviated a lot of times. What is overactive bladder? This is actually a very important definition. It's urinary urgency and urinary frequency, often, with or without incontinence. So you don't actually have to leak to have overactive bladder. You can be making it to the bathroom, but urgency to pee. I need to go. I need to get there right now. I can't finish what I'm doing. I'm, pushing people out of the way. I can't wait in line. That in and of itself is overactive bladder. And then nocturia is possible. It's included in the definition. It's not required, but the definition of nocturia is getting up more than once at night. So more than once is considered abnormal and generally not necessary for someone with a functioning bladder. Thank you. No, you're good. Next slide. So we talked about this. 2 or more visits at night is nocturia. Frequency, right? Of course, like this definition is a bit loose because obviously it depends on how much you're drinking, but if you're drinking, quote unquote, 8 glasses a day of water, more than 8 visits, 8 or more visits is considered excessive or too frequent. And then urgency is self-explanatory. So we can go to the next slide. How does this impact your quality of life? Some of this is intuitive, but if you are not afflicted by this, you might be wondering, constantly needing to pack extra things in case of an accident, wearing darker clothing, skipping social events. Bathroom mapping means wherever you go, you immediately have to find where the bathrooms are just in case, because you don't have time to figure that out with an urge. Very commonly, we will see folks limiting how much fluid they're taking in, and that can actually, people can come to see us in kidney failure because of this. This chronic fatigue is real and is a real problem. Getting up 4 or 5 times at night means almost no meaningful sleep, and people can be, delirious with this. And then social isolation. Of course, if you're not going out, you're afraid of leaving the house because of accidents. This can be very, very isolating and cause depression, etc. So we can go to the next slide. So what are some of the treatment options? So there are tiers of treatment. So next slide. This slide just goes over the first line treatment. So what we often see is a patient coming to see us and they say, okay, my primary care doctor gave me a medication for this and it worked or it didn't work. And the key to that is that medications are actually not the first line. There are things that some people are doing intuitively. They just are doing it because it feels like it's the right thing to do, but sometimes these are not that intuitive. So keeping a bladder diary is something that we encourage everyone to do to really get a handle on what is going on. Often if you just write something down, it can become a pattern can arise. Oh, every time I drink coffee, I have an accident. Okay, that's obvious. So a bladder diary just goes into when you pee, how much you pee, how urgent it is, what did you have to drink that day, how much did you drink, etc. Bladder retraining. This is something I'm going to spend a bit of time on, I think more than I normally would, because I've just been seeing a lot of this recently. There's something called timed voiding, which you'll see on this, which is not waiting an excessively long amount of time before deciding to go to the bathroom. For example, you felt the urge to urinate for 5 hours, 4 or 5 hours, and you're just pushing yourself. You're at work, you're with whatever you're doing, and you're just waiting. And by the time you get to the bathroom, it's an accident. So you don't want to do that. But there's a time where this becomes excessive, where some people will come to see us and they're voiding every hour intentionally because they know if they do that, they don't have an accident. For most people, voiding every hour is not conducive with a good quality of life, right? If that's not your scenario, then, have at it. But for a lot of folks, voiding every hour means you can't sit through a movie. It means you can't drive to see your family member, in South Carolina without stopping. It means a disruption generally. And also if you're somewhere where there's not a bathroom in an hour, it's a problem. And so it's important to know that there are boundaries here. And so bladder retraining is the concept that the bladder can be trained to hold more urine. And if it can also be trained to hold less. So if you're voiding every hour, an hour's worth of urine is going to feel full. And that's for most people, unless you're drinking a gallon of water at a time. It's not true. You can actually hold more than that. And so bladder retraining is learning how to push your bladder to hold more. So that's actually something we focus on a lot. Pelvic floor exercises. Yes, seeing a pelvic floor physical therapist is very helpful, teaching you techniques on how to stop urges when you get them, how to hold urine in when you feel that urge is too strong, and then improving the diet. This doesn't mean eating healthier. This actually is really important. This means avoiding bladder irritants. Many bladder irritants are healthy. So there's a fine line, right? You don't want to be, eating a bunch of things that are bad for you just because they're good for the bladder, right? But there's a line too. So that those things are important. We can go forward to the next slide. And so medications, quickly, there are a couple different classes. These are designed to help your bladder hold more urine by allowing the muscle to relax and fill more. So you can go to the next slide. There are side effects to medications. When you're relaxing a muscle in the bladder, you can relax processes elsewhere. And so these can cause issues with dry eye, dry mouth, constipation, fatigue. Some of these can increase blood pressure, slightly. There's a high discontinuation rate for medications, which is why, focusing on here's the medication as the first line of treatment is not a good plan. It's not a good strategy. It's generally, for most people, not sustainable. And there have been more and more studies come out that this one specific class of medications can cause a significant, like 30% increased risk in dementia with consistent use. That's this anticholinergics box. So that is usually not the focus. While they can be very helpful, it's generally not the focus for what we do. We go to the next slide. So third line treatment. So if first line and second line haven't worked, what can you do? So we can go to the next slide. There are procedures for this. The first one is it's a mouthful, bladder onabotulinum toxin A. It's just Botox, but Botox is a brand name, so we have to write the non-brand name. There are other, Dysport is another one. There are different folks that are making this product now. Posterior tibial nerve stimulation. All of these words are horrible. Posterior tibial nerve stimulation, or PTNS. We'll talk about that, and then sacral neuromodulation. We'll talk about as well. So we can go to the next slide. I will refer to this as Botox. Botox, don't sue me. But yeah, that's what we're going to talk about. It can be an office procedure. You don't have to have anesthesia for this. You can be awake, but you can get anesthesia if you prefer not to be awake during this process. So the picture is depicting a flexible camera going into a bladder, and a small needle comes out of the camera, and we inject little bits of Botox, the same Botox for the face, for wrinkles, for the neck, for migraines is used. And what Botox does is it just relaxes muscle. So in the same way the medications want to relax the muscle of the bladder to hold more, that's what Botox does. It takes a couple weeks to start to work, and it will wear off in a variable amount of time depending on how you process this in your body. But it wears off in 4 to 12 months. I've had some patients with an initial injection get to 18 months. So that's unusual. It's usually 6 to 9 months or so. We can go to the next slide. So PTNS, this is an office procedure, is used a bit loosely, but it's basically acupuncture. We put a needle behind the ankle. I think you can go to the next slide. It might be more helpful to look at this while I'm talking. So this is showing a person reclining, and at their foot there is a little needle. Go back one. There's a little needle with connected to a battery with a wire. It's like an electrode. And basically that needle is placed right next to this nerve called the posterior tibial nerve. We isolate that nerve because as it travels up the leg and goes into the pelvis, it crosses the nerve that goes to the bladder. So it's kind of indirectly affecting that bladder nerve. And by giving it a charge, that helps to kind of calm this nerve that goes to the bladder. We don't actually know what the true mechanism is, but that is how it's done. It requires 30-minute sessions every week for 12 weeks. So it's a commitment, certainly. But the advantages are there are really no risk factors. It's not truly a surgery. And so there are significant benefits for folks who maybe are in poor health or just can't tolerate some of these other things. You can go to the next slide. Since our last talk, there's now an implantable version of this. You can imagine folks who are like, yeah, this sounds great, but I don't want to come in every week for 12 weeks. You can have a little, it looks like a coin. I didn't show it because it's proprietary, but it looks like a nickel. It's the size of a nickel. That can get implanted in the same area, and you get a remote that looks like a phone, and you can turn it on that way and just control your sessions at home. So that's been FDA approved recently. I have not heard of widespread use of that in the Southeast, but in the Northeast, it's getting a bit more popular. You can go to the next slide. So this is sacral neuromodulation, which is a more direct version of what the PTNS is trying to do. So instead of putting a wire next to a nerve that goes up to the pelvis and crosses over another nerve, we just go straight to the pelvis and put a wire along the nerve that goes to the bladder. And then we connect it to a battery and we implant the battery in one butt cheek or the other. It is a pacemaker. That is essentially what a pacemaker is, a battery connected to a wire. And, in the heart, the pacemaker, the wire is put in the part of the heart that's kind of acting crazy. And then you just turn the battery on and it's working. The heart is beating normally. This is the same concept where you turn the battery on and it's working. So it's a bit like a light switch. It's quite cool, actually. It sounds like a lot and kind of crazy, but I think a point of what we're trying to do as urogynecologists is to destigmatize or demystify these things where it just doesn't make sense to be on a medication for decades and decades that one isn't working and has multiple side effects when you can have a 5 or 10-minute procedure that conveys, more results with less risks. Even though it sounds riskier, generally speaking, it really is not for the appropriately selected patient. Also, what's changed since the last time I did this talk is the batteries last longer now. They used to have to be replaced every 5 years. Now it's every 15 years, and they are all MRI compatible, which is also new. You can test this before you actually put the permanent device in using some temporary wires and an external battery for a few days to figure out if it's going to work before you have this device put in. You can go to the next slide. So that was like a quick and dirty review of overactive bladder options. There are kind of more expansive things to talk about, but that's sort of the first, second line, third line snippet. Pelvic organ prolapses is probably the second most common thing that we deal with as urogynecologists. What is this? So people will come to us and say, okay, I was told my bladder is falling out or falling down. I think that implies the bladder is the problem, but it's not. So the issue is that the support for the pelvic floor, or the support for the vagina, is failing. So as the vagina falls, or kind of the inside of the vagina, think about it like a sock, right? The vagina is sort of turning inside out, or you're turning the sock inside out. It's dragging other things along with it. So it can drag the bladder down, it can drag the rectum down, can drag the uterus down. But there's nothing inherently wrong with the bladder or the bowel or the uterus. It's the support. And all of these things result in a bulge from the vagina. And that's what patients feel. I feel like something's coming out of me. I feel like a tampon is halfway out. I feel like I'm sitting on a ball. I just can't get comfortable. I'm kind of shifting in my chair, trying to move this thing. I have to push something up to pee or to poop. That's prolapse. So you can go to the next slide. So this is kind of a schematic of all these different things I explained, like what part of the vagina is coming down. They have all these different names. It's helpful in terms of how we treat it, but it's less helpful for the patient to identify these things. It's helpful for us, though. You can go to the next slide. So what are management options that you can do that are not surgery? There are many. Here comes pelvic floor physical therapy again. I thought that was helpful for overactive bladder. It's helpful for prolapse. It's helpful for weakness of the pelvic floor. So, if we lived in a different country with socialized medicine, folks go to see pelvic floor physical therapy 6 weeks after they have a baby, right? It's because there's significant trauma that's caused by that. And, that's recognized and managed proactively. There are also other things, vaginal estrogen. We'll talk more about that. But essentially, vaginal estrogen is kind of the backbone of the pelvic floor support. So not only can it help to kind of bolster the ligaments and the muscles and the soft tissue, it can help to calm nerves down. So it's also helpful for overactive bladder symptoms. And it's really one of the first things we do for postmenopausal women. And then pessaries. This is a view of what pessaries are. A lot of folks have never heard of this word, so just a visual of it. These are devices made of silicone that act just like props, essentially, of the vaginal walls. When the pessaries inside, you don't feel it. It is pushing the bulge away from the opening of the vagina, so you don't feel a bulge. But it's removable, of course, and not a surgery. So you just have to get fit for the right one, and we do that in the office. So you can go to the next slide. There are many, many surgeries. So it's important to understand, if folks come in and say, okay, I just want to have the surgery. That does not exist. The surgery does not exist. It's a conversation between us in terms of, what are your goals? What do you want to keep? What do you want to lose? What's actually bothering you? So I mentioned on the side here, we can use just your own tissue. We can use a mesh to help to support the repair. We can do things vaginally. We can do them laparoscopically, through the abdomen. We can keep your uterus. We can take it out. This all just depends on patient preference, and then also various safety issues. For example, if you have concerning bleeding or something from the uterus, your uterus should come out. Doing a procedure to keep the uterus would probably not be the safest option. So things like that are the conversations that we have. But essentially, we're just trying to figure out what can we attach the vagina to lift it up, and how are we going to do that? That's really the crux of prolapse surgery. So you go to the next slide. I went into kind of these schematics of the types of surgeries. I see this message pop up here, and I'm just going to answer this. How old is too old to have prolapse surgery? There is never a too old to have prolapse surgery. There's a too sick. That matters, but the age does not. There are different types of surgeries that we do that are less invasive, quicker, safer, but the age is irrelevant. If you can imagine, most of what we do is on women who are 65 and older. Certainly we do prolapse repairs on women who've just had their babies and they're in their 20s and 30s, but the vast majority of patients are Medicare age 65 and over. So there's not too old. I think the oldest patient I have ever operated on was she was 101 years old. And if you're bothered by your prolapse at 101 years old, you're probably doing well, because that's your most bothersome symptom, and you're well enough to undergo anesthesia. So there really is no age restriction. You can go to the next slide, because I think the specifics of the types of the procedures is not that helpful. Okay, I specifically want to talk about gynecologic malignancies, but I recognize that everyone in the group may not have a gynecologic malignancy, or that may not be their issue. So some of these things can be extrapolated to other ones. So we can go to the next slide. So what are the rates of pelvic floor disorders by the type of specifically GYN cancers. It's a bit of a busy slide, but the first pelvic floor symptom is any kind of urinary incontinence. And this is, 2 or 3 times a week is what I highlighted. So you can see it in that highlighted area. The overall rate was almost 13% of people. But folks who had uterine cancer had more of this than others. If you go down to stress, urinary incontinence, that's leakage of urine if you're coughing, laughing, sneezing, that sort of thing. Of all types of GYN cancers, it's almost 75% of patients. And then that kind of like on par, vaginal, vulvar, ovarian, and uterine cancer all had similar rates of that. Urgency incontinence, we see almost 70% of patients have that. Much higher prevalence here, kind of across the board, whereas pretty standard in the 60s to 70% for most folks. So common, very, very common in GYN cancers. You can go to the next slide. What is the prevalence of these cancers, of these pelvic floor disorders in patients who are GYN cancer survivors? And this little screenshot looks at what are the prevalence of these things before and after treatment. And you can see, the big picture of this is that some pelvic floor disorders get better after treatment, but for the majority of them, they will get worse after treatment. And that's often because the treatment includes a hysterectomy. That's a risk factor for pelvic floor disorders. The treatment could include radiation, as I talked about. Chemotherapy, I didn't mention specifically, but that can worsen pelvic floor disorders by disrupting nerve function and things like that in the pelvic floor. But generally speaking, if the understanding is there that the prevalence at baseline is very high and the treatment can worsen this, there should be some level of consciousness of this and addressing this proactively. So you can go to the next slide. Generally speaking, there are not a lot of great data because you can imagine most research in cancer patients is focused on treatment of cancer and safety, efficacy, and cure rates, et cetera. But quality of life matters. And so, this is something that's understudied, but I think getting a bit more recognition recently. Most commonly studied are cervical and uterine cancer. I think that it's because, this is my bias, but generally these are things that affect younger patients more often, and younger patients may be more apt to disclose or complain. That's complain in the medical sense of these symptoms more than older patients. That's been studied and been shown that being more forthright with those symptoms as bothersome is more common when you're younger. And then ovarian cancer, there's almost no data. I think because ovarian cancer is, of the GYN cancers, the most aggressive, the most deadly, there's much more research looking at treatment. And that's, I think, understandable, of course. We can go to the next slide. This can talk about quickly, but with cervical cancer, you can imagine, a radical hysterectomy is performed where basically the uterus is taken out, but the top of the vagina is removed as well, sort of like almost a half of the vagina to really make sure that all of the cancer cells are gone. And then sort of going to the side walls of the pelvis, the is removed as well. So a lot of nerve disruption happens compared to, a nerve sparing type of surgery, have less urinary incontinence. That's UI issues with that. Of course, radiation can cause more urinary incontinence and fecal incontinence than patients without radiation. And then surgery can be more associated with immediate urinary issues, but radiation, of course, as the effect is delayed, has more delayed issues. And then with respect to uterine cancer, the PORTEC trial gave us a lot of good data. This may be familiar to some folks in the chat, but generally speaking, a lot of symptoms of urinary incontinence, dryness, dysfunction with both the radiation and the local radiation brachytherapy and radiotherapy groups. So a lot of issues there. So we can go to the next slide. What are some special considerations when I'm seeing a patient who has a diagnosis of cancer and they have a pelvic floor issue? Certainly, we need to prioritize. We're not going to delay cancer treatment because of a urogynecologic issue. And so, it's important to understand there are some patients who maybe they were diagnosed with, for example, uterine cancer. They had no symptoms other than, vaginal spotting once in menopause. But the real problem they have, problem meaning quality of life issue, is their incontinence. We would not delay their care in order to manage incontinence. We would work together and try to get things done expeditiously, but certainly the cancer would need to be treated as a priority. Again, expediting care to facilitate a coordinated surgery is something that we do all the time. I have really good relationships with Northside GYN cancer surgeons, and we talk or text nearly every day. So that's really the prevalence of how often we take care of this. Thinking about what are some alternatives for patients who maybe our typical procedures are not appropriate. For example, mesh in a patient with radiation, you really want to avoid that. So talking about non-mesh procedures, et cetera. And then just making sure, again, like medical and surgical oncology work well. I speak with medical oncologists 5 to 6 times a week about, for me, usually estrogen-based therapy, local therapy for some of these pelvic floor disorders. So just having a good relationship is really important. We can go to the next slide. I think we can skip this slide, but basically this says, if you have a coordinated procedure to fix stress incontinence at the same time as uterine cancer, patients are happier. I think that's intuitive. And then I think there was a comment or a question that came up of the management of, like, could you use estrogen if you have an estrogen receptor positive cancer? So the genitourinary syndrome of menopause, or GSM, is this group of disorders that have sexual side effects, urinary issues, genital issues. And the concept will always be to try non-hormonal things first, because if they're effective, then wonderful. But in general, these things don't work that well, or maybe work somewhat, but aren't getting the patient to where they are happy and their quality of life is improved significantly. And so we can go to the next slide. Which talks a bit more specifically about vaginal estrogen use in hormone-sensitive cancers. So big picture here is vaginal estrogen is not hormone replacement. So it's formulated to specifically not increase circulating levels of estrogen in the blood. I think the consensus statement is that the effect of circulating estrogen is negligible for vaginal estrogen cream used appropriately. That being said, if a patient is actively undergoing treatment, I will always defer to their medical oncologist with respect to whether or not vaginal estrogen cream is safe for them. So patients often internalize the word estrogen and unsafe because they have been told that, but estrogen is often used as a substitute for hormone replacement, which estrogen cream is not. Local vaginal estrogen cream is not hormone replacement. So this is where the miscommunication occurs. And so we'll always defer to the medical oncologist, but I will tell you, in doing this, I have not had a circumstance where a medical oncologist has said, absolutely not, my patient cannot use vaginal estrogen cream. And these are patients who we think are appropriate estrogen cream users. There are certainly patients who are not, and so that's out of the scope of this talk. But it's important to understand the difference. So I just want to take a little bit extra time talking about that. The next slide says the same thing, so you can skip over that. So the take-home points, you can go to the next slide, are for the provider, which I'm not sure if there are providers on this talk, ask about these issues. They're extremely prevalent. 60–70% of these patients will have these issues. So ask about them. And then we're here. So know who we are. This is the only thing we do. And I hope there are some on this talk. And then for the patients, yes, you may be having a consultation about your cancer treatment, but if you have these issues and it is, somewhat related, or you think it's somewhat related, to the type of cancer, the provider that's taking care of you, mention it, speak up, because even though they probably aren't the person who deals with it, they should know who that is, and they should understand that, a quality of life issue, it's important, and there are people who do this like me. So voicesforpfd.org is the patient advocacy website for the American Urogynecologic Society, which is our governing body, and there are tons of great resources there. So I encourage everyone to visit that. You can go to the next slide. And that's me. We have 3 offices. I don't go to our Athens one, which is in the middle. Dr. Rabin and Dr. Milan are our surgeons there, but I go to our Alpharetta office and our Buckhead office, which is sort of, sandwiched, I guess Northside, Sandy Springs, or Atlanta is kind of sandwiched between those 2 offices. So pretty convenient to both. I believe that's it. I think my next slides are the references. But thank you. And Mira, take it away. Thanks.
Thank you so much, Dr. Ford. That was so enlightening. Honestly, it's such a treat to hear from yourself, an expert physician, surgeon, on how you approach these pelvic floor disorders that affect so many women and so many people going through cancer treatments and survivors. So I kind of want to talk about where pelvic health PT can fit in terms of addressing any pelvic floor disorders. Next slide, please. So first and foremost, I am a physical therapist. If you've been a PT before, you might know that we focus on the musculoskeletal system. And in pelvic PT, we're looking at the pelvic girdle and the pelvic floor muscles and how they might contribute to symptoms relating to bowel function, bladder function, prolapse, and pelvic pain. So your pelvic floor muscles, they go from your pubic bone in the front to your tailbone in the back, and they surround the urethra, the vagina, and the anal sphincter. Now, when you contract these muscles, you're closing these 3 openings. If you're familiar with the term Kegel or Kegel, that describes this contraction. We do want to be able to contract in order to maintain bowel and bladder control as well as pelvic organ support. But your pelvic floor muscles also do need to be able to relax in order to urinate, have a bowel movement, have intercourse, tolerate a gynecological exam. And if your pelvic floor muscles are working properly, ideally, you wouldn't have to think about it. They'll contract at the right time, they'll relax at the right time. If you are symptomatic, then speaking to your provider to discuss treatment options and to determine if you're a good candidate for pelvic PT. Next slide, please. So this is a nice little summary of, again, why it is important for our muscles to be able to appropriately contract and appropriately relax. So when it comes to therapy, we don't just categorize your muscles as being strong or weak. We look to see if they're overactive and underactive. Both can cause weakness and symptoms. So what I'm trying to say is Kegels are not always the answer for everyone. If your muscles are tight and you're doing Kegels, they can make things worse. So, bring up your concerns with your doctor for further examination before choosing what exercises to do. Next slide, please. All right, so here we have some of the commonly treated diagnoses that we see in pelvic PT. You can see, again, they pertain to bowel function, bladder function, pelvic pain, and sexual dysfunction. Survivors are certainly vulnerable to these diagnoses based on their cancer treatments, specifically surgery and radiation, but it's also possible to be suffering from one or more of these, even before a cancer diagnosis. That is because pregnancy, hormonal changes in age are all risk factors for urinary incontinence, for fecal incontinence, and pelvic pain with vaginal penetration. And, for many of these, it's kind of accepted in society. Well, this is just what happens when you get older. But just because something is common doesn't mean it's normal. So don't settle if it's affecting your quality of life. Next slide. So let's say you've been referred to pelvic PT. This is what you can kind of expect on your first session or your initial evaluation. The point of that first appointment is to figure out your medical history, your symptoms, and why you're experiencing the symptoms that you are. We do spend a lot of time investigating your symptoms, sometimes even when people don't think it's related. For instance, if you have a prolapse, but you also suffer from constipation, well, straining on the toilet could make that prolapse worse. So we also need to address the constipation. Or if you come in because you're not emptying your bladder completely, but you also have a history of pelvic pain with intercourse or gynecological exams, again, these are likely related, and we want to know about it. So really the purpose of that initial evaluation is to create a customized treatment plan and set realistic goals for you. Next slide. All right, so now you know what our assessment looks like, but what do we do? How do we help you reach your goals? So these are our most frequently used treatment strategies. We always start with education, behavioral change. Dr. Ford touched on this too, because it's that important. Honestly, you can do all the exercise you want, but if you're drinking 2 bottles of water before bed, you're probably going to wake up at night to urinate. Or if you're hovering over the toilet, maybe you won't empty your bladder completely. That'll make your urgency and frequency worse. So there's a lot that you could probably improve upon just with behavioral change. We also do manual therapy. If you have scar tissue restrictions that are painful, we can work on that. If you are having any kind of pain or any kind of radiation fibrosis, manual therapy can help there too. We do exercise, of course, for physical therapy. Now, if we're trying to down train because someone's muscles are really tight, the exercises might be more specific to breathing and stretching. If we're trying to up train someone's pelvic floor, then we might focus more on strengthening the hips, the core, and the pelvic floor. Depending on your goals, we might also go over how to return to your preferred method of exercise without leaking, with appropriate pelvic organ support, and while protecting your pelvic floor. We also use biofeedback and dilators in our therapy in certain cases, and actually we'll touch on that in a minute. Next slide, please. All right, there's a lot going on this slide, but I could not help myself. So let's talk about what's normal. Dr. Ford mentioned some of these as well. So a lot of times pelvic floor symptoms kind of creep up on us. Maybe you used to only leak when you sneezed and your bladder was full, and now it's every time you run. Or maybe you only had urgency when you'd come home, and now it's every time you make eye contact with the toilet. So we tend to move further away from those healthy habits kind of gradually. So let's go over what's normal. So it's normal to go to urinate 5 to 8 times a day, no more than once per night. Again, you want to avoid going just in case. When we do that, we're kind of making our bladder more sensitive to smaller amounts of urine. Minimize bladder irritants. You do need to sit to urinate. That's a non-negotiable. And you shouldn't be pushing the urine out. Mid-urine stream is also not when you should be practicing your Kegels, if they're appropriate for you. And please take your time to empty your bladder completely. For your bowels, here too, avoid straining. Using a footstool and leaning forward can help relax your pelvic floor, making it easier to empty your bowels. Keep your stool soft with management of your diet and hydration status. And bowels, honestly, they love habits. So having breakfast, having a consistent morning routine at home to allow yourself to feel the urge and then go can be really helpful. All right, next slide. So I mentioned biofeedback briefly. Biofeedback is honestly a wonderful tool that we use in our sessions to help retrain the pelvic floor. Now, if you're doing a bicep curl for exercise, you can see your muscles, you can see your arm moving, you can tell how much you're lifting. When you're exercising your pelvic floor, now they're internal muscles. So you're relying on your sensation and awareness, and that can be challenging. So biofeedback can help us bridge that gap. Basically, we put some sensors on that pick up pelvic floor muscle activity, and it connects to the machine. And when you tighten your pelvic floor muscles, it will go up. When you relax, it'll go down. So it allows us to uptrain if we need to and work on exercises, or downtrain if the muscle is really tense. So this is something we use often. I kind of describe it as like a video game for your pelvic floor. It does bring out the competitive side in some people, but it really helps build that mind-body connection. All right, next slide, please. All right, so some of you might be familiar with vaginal dilators. Often women do receive 1 or 2 dilators after radiation treatment. So radiation can cause narrowing, dryness, and scarring of vaginal tissues. Hormonal changes can also cause narrowing and dryness, and these changes can make it difficult to have intercourse or tolerate a gynecological exam. Honestly, even if you're not sexually active, it is important for your doctor to be able to have complete a gynecological exam. So that's kind of where dilators fit in. They are a wonderful tool. If you come in and we determine that you'll probably be a good candidate, we'll go over, if we advise a silicone set or a plastic set, we'll show you how to use them, demonstrate on the model, and we might use them in the clinic as well. Rather than people kind of using dilators on their own, I do find that purchasing a whole set and coming to therapy has people just stay more consistent with them, which helps them progress more and keep moving up on the larger sizes, which will keep moving you forward. So, I know they can be intimidating, but they are a very useful tool that we do have success with. All right, next slide, please. So, finally, if you're having any of these symptoms, please do bring them up with your provider. They really, really do want to know about it. You can have a conversation with them to determine what are your treatment options, the best course of action, and if you are a good candidate for pelvic PT, these symptoms can certainly negatively impact quality of life. And again, they're common, but not normal. So if you are looking for an exercise-based approach, pelvic PT can help. All right, I think that was it, Katie. I just have references and our locations for Northside Hospital Rehab Services.
All right, thank you, Mira. And I think Dr. Ford and Mira agreed to hang out a little bit longer to allow for some Q&A. So if you guys want to go ahead and take this opportunity to enter any questions into the program chat box, and we will address those now. Mira, do you have any that you have lined up over there?
I think I have 2. I got one recently, which I think I touched on, but I'll read it out. So I've been told it's not good to squat or hover when using a public restroom because it doesn't really allow your bladder to empty properly. Thoughts? So yes, if you're hovering, you're tensing your pelvic floor, but you really need to relax in order to empty your bladder. And you do need to sit with the rare exception, put down toilet paper, try to make yourself comfortable, but it is important to empty your bladder completely. All right. Dr. Ford, I had a question earlier. Does too much salt and sugar intake increase urge to urinate?
That's a bit of a mixed bag because the answer is like yes and no. Too much sugar in and of itself, sugar is not like a diuretic. It doesn't make you make more urine, but one of the risk factors for urinary incontinence is diabetes or elevated blood sugar. So that certainly can be an issue. And then interestingly, with salt, so what salt wants to do is to draw fluid out of your blood vessels and into your tissue, right? And so that can actually make you make less urine. But what's very interesting is when you go and lie down at night, all of that stuff that's collected in your tissues and all of that wants to come back into your blood vessels and then go to your kidneys and then make urine at night. So that too much salt intake is a big risk factor for nocturia, as we talked about, getting up at night a lot to avoid. So it's sort of both, I think.
So someone else has a question. Does insurance cover Botox or sacral neuromodulation?
Yes, and yes.
Awesome. And if you have a GI cancer and they remove lymph nodes, are you at a higher risk of having a pelvic floor disorder?
Not specifically from, should I say that? Okay, there is, what's the exception? If you have a lymphocele where your lymph nodes would generally be collecting lymph fluid, but now you don't have those lymph nodes anymore and that fluid can collect. There are rare situations where you can get almost, it's a lymphocele, it's like a collection of fluid in the abdomen, which can cause a lot of pressure. And once in my career, I've had to do a prolapse procedure for a patient who just had persistent lymph fluid collection. But that was excessive. So I think generally no, but in very rare cases, possibly. Yeah.
Gotcha. Okay. So someone asked about the photos sitting on the toilet. Is there a certain way that we need to sit? So yes, having a footstool and leaning forward, you're kind of trying to mimic like a deep squat, just with Western toilets. So sitting with a footstool that brings your knees higher than your hips would be the ideal toileting posture. Honestly, it helps with bladder emptying too. Okay, someone asked, can they address expectations when kidney stents have been part of the treatment? So I interpret that as like, will that cause any urinary or bladder symptoms?
While I should say I don't place indwelling kidney stents, that's a urologist, but we see patients who have stents. Yeah, stents are horribly irritating, painful. Stents are generally short-lived and are going to be removed in a few weeks. And so we wouldn't really aggressively manage anything until the true bladder symptoms are revealed once the stents are out. So but having stents it's a very hard time for everybody. And, hopefully it's short-term for the writer.
Can you go over a little bit about which foods and fluids, I guess, could be bladder irritants?
You want to take that, Mira?
Sure. So, everyone is different on the whole, citrus. So don't add lemon or lime in your water. Sometimes spicy food, acidic things, tomatoes could be bladder irritants. Carbonated drinks, artificial sweeteners, caffeine, alcohol, those can certainly all be bladder irritants. I find that not everyone is as sensitive to all of them. It's kind of on a spectrum. So if you're having 6 cups of coffee a day, not great. If you're having 1 in the morning, maybe that's not affecting you 12 hours later. So completing a bladder diary, like Dr. Ford mentioned, even maybe a food diary with it, because a lot of foods do have high water content, can give you a lot of insight, like having 2 cups of watermelon in the evening for dessert, that might affect you too. So a lot of factors at play. All right. Someone has mentioned they have had a hysterectomy, chemo, and they have had some neuropathy. So they're kind of having trouble, difficulty urinating, but also having urinary leakage. Any thoughts on someone experiencing that?
Yeah, it's tricky, right? Because it's common if it's hard to pee, but you're leaking. What are the options? So the first thing to do is really to diagnose the true problem, and we do that with some sophisticated testing, specifically something called urodynamics, where we figure out, what exactly is the reason for poor emptying, how bad is it, and then we get a sense of what is causing the leakage. Is it, for example, something called overflow incontinence, where you're really not emptying well at all, and so it's just that the bladder is overflowing, essentially. The treatment of that is very different from someone with retention, or you can't urinate because chemotherapy or radiation has damaged the opening of the bladder and it's just hard for it to expand. That can also happen, as I said, with chemotherapy and neuropathy. There can be specific neuropathy to different areas of the bladder, which make it difficult to empty. So there's not a blanket answer for that, but it is a common issue that we are accustomed to dealing with. It's just about what is the reason for each of the issues and how can those be treated effectively.
Okay. Someone has asked, from a urogynecologist standpoint, are there any specific questions to ask a radiologist before radiation? Should I meet with the urogynecologist at the same time?
I would say that in terms of should you meet with a urogynecologist at the same time as a radiation oncologist, I think that a urogynecologist visit should be in tandem with all of the care, all of the cancer care. Whether that's at the same time or not, I think there should be some conversation about expectations from a urogynecologic standpoint after radiation. And it would be, if it were me, nice to know about things ahead of time. However, as I said before, it should not delay your care, your cancer care. And then specific questions to ask would be, how much radiation would you anticipate that I would need? Where would this radiation be directed to? And then these are questions that they're used to answering and would usually give these to you unprompted. And then also tell me about ways that we as a team are using to minimize radiation damage and sort of side effects of radiation. And they'll kind of go through those things with you. That's a standard part of their care, but those are basic questions.
Okay. I often have people that might have come from like a primary care physician or like a colorectal physician, and I notice that maybe their gynecological needs aren't being met, and they'll be like, well, I don't have a uterus, I don't need to go to the gynecologist anymore. But there are still so many elements of care that are needed, and often I refer women to urogynecologists to make sure the estrogen status is good, the pelvic organs are supported, and just because you don't have a uterus doesn't mean you don't need care.
Very good point. Yeah.
All right. Someone asked, how much of a correlation have you found with fibroids and urinary incontinence, particularly in Black women?
Honestly, they have to be specific. For example, fibroids is like in a couple scenarios. Fibroids either need to be so large that they're creating a pregnant-like effect, where it's just a mass effect on the bladder, pushing the bladder down, not allowing the bladder to expand fully. That is either uterus that's 8-9 months pregnant size, or 12-week size. It's a very specific size where it traps the uterus in the pelvis, and it's where kind of if you have the backbone coming down and it arches to make your sacrum and your tailbone, it's where the uterus is just the perfect size at the pelvic inlet where it can sort of trap it right there. So there's that, which is a very specific instance. And then other locations of fibroids where they might be very prominent and kind of at the front of the uterus, pushing right against the bladder, where the whole uterus might not be very big, but the one fibroid is just in the perfect spot. And then a third circumstance is if the fibroids are degenerating or dying. This is where they outgrow their blood supply and they start to almost like decay. That is a very painful and irritating process. And anything that's kind of irritating and right next to the bladder is going to make the bladder get irritated. So that can cause some urinary issues, but that's usually shorter lived. But I would say that in general, fibroids need to be very specific to cause urinary incontinence, but possible.
Okay. Let's see. Someone did ask how to do a Kegel. So some cues that I usually share with people. My favorite one is imagine you're picking up a marble, you're closing around the vagina and pulling in. We'll have, we have different. Are you doing it right now?
Did
We had a giveaway.
Do I do? Yeah.
No, actually, you did pretty good. I just saw your eyes moving. I have I call it the New York City subway test, right? So if you're doing it right, no one should be able to tell that you're doing it.
That's a good one.
So
yes.
Hopefully that brings some clarity. All right, one more question. Someone said they had a laparoscopic assisted vaginal hysterectomy, BSO, colpopexy, posterior repair, and transobturator tape in 2010. When might I need surgery again?
Great question, and there's no answer, unfortunately. These procedures generally don't have a lifespan, but if the colpopexy you had was a sacrocolpopexy, there is like 10-year data that says the recurrence rate is about 5 to 10%, right? And so that's if you looked at everybody 10 years later, 5 to 10% of them will have their prolapse come back. So that means 90 to 95% of people won't. Unfortunately, we don't have like 20, 30, 40-year data, but there is no time limit. There are so many things that affect recurrence. For example, if during that time you've gone through menopause, if during that time you've had a cancer diagnosis and been treated for cancer, if you've gained or lost 30 pounds, if your lifestyle's changed a lot where you're now much more active compared to before, these are different things that can affect things. But certainly there's no, anyone that says, 15 years, you're going to need a new one, they're just making that up. That's not true.
Okay, I have one more. Someone wanted to confirm that estrogen positive breast cancer patients can use estrogen creams.
So this is where there are some nuances. And again, where your medical oncologist is the authority. I think I want to make sure that that's very clear. The person who's managing your cancer medically is the authority and will ultimately have the say so. But for most patients that come across my desk, most patients are able to receive vaginal estrogen cream for the fact that it's not hormone replacement. But again, I would never make that decision independently without consulting a medical oncologist.
Sounds good. I think those are all the questions we had today.
Awesome.
Thank you, Dr. Ford, and thank you, Mira, so much. And thank you guys for hanging out. I know we went over, but it was just so much great information and everybody had such good questions. So thank you, everybody, for hanging out longer than expected, but we appreciate it. And we got a lot of positive feedback in the chat box. So thank you, Mira, and thank you, Dr. Ford. As a reminder, a recording of today's program will be sent out to everyone that registered for the program. So if you know someone who missed it, you can find a recording on our website, but you will also be seeing a recording link in your inbox soon. So again, thank you, and please visit us, cscatlanta.org, to see everything that's available to oncology patients. And I'm about to put information on how to connect with Dr. Ford and Mira in the chat box as well. So we're getting a lot of thank yous. Thank you both, and we hope to see everyone soon. Take care.
Thank you so much. Bye-bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.